Thank you, sir. Thank you, organizing team, for giving me the opportunity. I will start with the presentation. So, to give a brief background, low-grade urothelial bladder cancer is sensitive to multiple chemotherapeutic agents like mitomycin and gemcitabine. There are two main things that are important for drug delivery, that is drug concentration and dwell time. However, the continuous drug dilution due to urine production often reduces their efficacy. So, the trial which before these two trial was done, in which 22 patients were recruited and complete response of 36% was observed. So this was the basis of further studies. So first I'll speak on the first journal, which was the interim analysis of mitomycin-containing reverse thermal gel, known as OLYMPUS trial. So how does it work? Basically it consists this gel consists of mitomycin and RT or reverse thermogelation hydrogel, which the property is when you inject it inside the body, it forms a semi-solid gel depot inside the calyceal system, and with passage of normal urine, it gets dissolved and gives a tissue exposure of more than 4 to 6 hours. The mechanism of tumor cell destruction is that of mitomycin, that is predominantly DNA alkylation, and others like redox cycling, RNA inhibition, and thyroidoxine reductase activity. The methodology, it was an open label single arm phase 3 trial. Inclusion criteria were a patient more than age of 18 years, primary or recurrent tumors, and diagnosed within 2 months of screening with life expectancy more than 24 months and ECOG of less than 3. Exclusion was if patient has a coexisting ureteral tumor or had bilateral tumors without other kidney being removed, or a patient had received BCG in past 6 months or was currently getting a BCG treatment. So protocol, patients were eligible to receive a 6 once weekly treatment of thermogel, which was that concentration was 4 mg mitomycin per ml of gel, and it was instilled into the callus and pelvic calyceal system using a retrograde ureteral catheter. The instilled volume was determined by 3 independent fluoroscopic guided measurements of volume of the collecting system. And the idea was not to instill more than 15 ml, that is the maximum dose of 60 mg. After completion of 4 to 6 weeks, after the completion of this 6-week installation, patient were again subjected to ureteroscopy and selective upper wash cytology or any biopsy if there was any lesion seen. And patient with complete response at this stage was considered then eligible for follow-up study, which will be discussed in subsequent journal. A patient with partial response were referred to the standard of therapy. The primary endpoint was to see the complete response. The secondary endpoint was to see the durability of this response at 12 months. And other second response were to see this ablative effect of 3, 6, and 9 months. Out of 110 patients which were screened, approximately 71 were treated after excluding the patients. Out of these 71, 61 received total 6 installations, and among them 19 had partial response, so they were excluded. Total 42 patients were eligible for follow-up study, and out of which 1 patient withdrew consent and 41 underwent follow-up study. Out of these follow-up patients, around 29 received at least 1 dose of maintenance, and 23 did not receive any maintenance therapy due to adverse events or a decision by the investigator, and 6 were ongoing receiving the treatment. Baseline characteristic, the mean papillary tumor size was around 15 mm, and tumor burden was around 19 mm. Most of these tumors were papillary. Treatment adherence, this was an important point. The 61 out of 71 treated patient completed total 6 installations as per protocol, and out of them 10 did not continue the treatment, and majority were due to the adverse effects. Primary outcome, complete response was seen in 42% of the individuals. This is at the primary at the primary assessment, that is post 6 weeks installation. And no response, no complete was seen in 29, among which 8 had partial and 12 had no response. Now follow-up. Out of these 42 patients which were eligible for follow-up, 41 entered, 1 did not give the consent, and 29 of them at the time of this primary interim analysis had received 1 dose of maintenance, and 6 out of 41 were still receiving maintenance at the data cutoff point. And 26 of them had reached a 12 months point interval, and 20 of them had 12 months assessment done. 6 patients out of these 41 eligible for follow-up had recurrence after complete response, but none of them progressed to high-grade or invasive cancer. At the time of recurrence during Kaplan analysis for durability of response, it was estimated at 84.2% at 12 months of interval. Now, adverse effect, the predominant adverse effect was ureteric stenosis and urinary tract infection, hematuria. These were the three main adverse effects which was noticed in this group of study. The others were related to the chemotherapy like vomiting, abdominal fatigue, pruritus, and asthenia, chills, etc. 2 out of 42 patients, that is 4%, developed ureteric stenosis for which radical nephrectomy was offered. And although the specimen in both the cases showed absence of residual cancer. Now, final analysis was done, and out of this 41 patients, 23 remained in complete response at even 12 months. And among them, 17 received only one maintenance therapy, and 6 did not receive any. Out of these, 8 experienced disease recurrence at 3 months, and 5 at later period, that is after 3 months. Out of these, 10 were unable to be evaluated. So at the end of 12 months, the final Kaplan analysis of durability response was estimated at 82%, which was still encouraging. Now, need for nephrectomy. This is an important data point. Out of these 71 patients, 8 eventually underwent nephrectomy. Of these, 2 were considered complete responders, but these 2 had ureteric stenosis, which we discussed, and both required nephrectomy, although they did not have any cancer at the time of final pathology. The remaining 6 patients considered non-responders and recommended radical nephrectomy by their treating urologists. At the final point, the main, again, the adverse effect profile, the main adverse effect was, predominant adverse effect was ureteric stenosis, which was seen, and it is correct. And there are 2 different comparative groups. The first group were the patient who received less than 6 installation, and the other group was that is more than 7 installations. So it was seen that dose related, the more the dose, more the installation, higher were the adverse effects. So since trial initiation till final database point, out of these 71 individuals, 23 patients had no recurrence in the treated kidney and still remain alive. That is 32% complete response. So critical appraisal methodology related direct comparison of recurrence rate in this study and local recurrence rate in UTUC population treated endoscopically is lacking. And this can be due to very low number of these individuals. This is a retrospective study, so had recall bias, a small sample size, and lack of control arm are other methodology related issues. Also, heterogeneous patient population and length of follow-up is also not adequate. Patient-reported outcomes were not measured. That is, the side effect profile or tolerability were not assessed. Treatment-related use of maintenance was not consistent. That is, 12 patients among them received nothing. 3 received maximum doses allowed in this study. There was no clear association between the durability of response or any number of maintenance therapy. That is, in complete responder groups, around 59% received maintenance therapy, and 50% of this complete response did not receive any maintenance therapy. Increasing maintenance dose are also associated with increased incidence and severity of ureteric stenosis and incidence of urinary obstruction events. Patients who had partial responders were shifted to other ablative treatment, and said there is no comparative or any appendix given on how did they respond. To conclude, installation of UGN-101 or mitogel once a weekly for 6 weeks is effective for primary chemoablation of low-grade UTUC. Final analysis suggests that there is a durability of response in majority of these patients up to 12 months following induction therapy with or without maintenance therapy. Ureteric stenosis is a significant adverse effect and at times required RNU. This could be due to multiple interventions, multiple ureteric catheterizations. More robust data is required, preferably multicentric, to generalize these results. Till then, it still remains an experimental therapy. Thank you.